What's up, everybody? My name is Christian Letzinger. Welcome to my Family Theory Young and Middle-Age Adult Disease presentation on gastroesophageal reflux disease. Right up front here, I'll be honest, I thought of 5 different titles and title cards for this presentation, and I couldn't decide on my favorite, so I'm just going to give you all of them, and you can decide on your favorite, and that will be the name of this presentation for you. First up, we have Gut Check, Unraveling the Ups and Downs of GERD. Because what goes down your esophagus if you have gastroesophageal reflux might come right back up. And so what's more fitting of an image than a roller coaster? So I photoshopped a roller coaster that goes up and down and around and turns into an esophagus, because why not? Title card number 2, The GERD Guide, Navigating the Acidic Waters. For this, I told an AI image generator to create a National Geographic style photo of a piece of pizza and a taco whitewater rafting on a river of green acidic fluid. And that's what it gave me, and I thought that was pretty cool, so I kept it. Becoming GERD Gurus, Mastering the Art of Acid Management. For this, I created a little green blob, flubber-like blob of stomach acid who was meditating, and photoshopped him into a stomach, because he's cute. Next up, one of my favorites, the Acid Avengers, Uniting Against GERD's Fiery Wrath. Alternative working title is Guardians of the Galaxy. And they're here to help prevent GERD. And so we've got a couple preventative measures and some therapeutics. So we've got antacid, the blocker, as in histamine 2 blockers, Miss No Spice, Nosmo King, because if you have GERD, you should not be smoking, no smoking, and the inhibitor, as in proton pump inhibitors. It's just a merry band of superheroes. Next up, reflexive thinking, understanding and coping with GERD. So for this, we've got a brain that becomes an esophagus and a stomach so that we can think about our reflux. Pretty straightforward. And lastly, for my Parks and Rec fans, you heard of GERD with Perd? I'm your host, Perd Hapley. Let's just do this presentation. I've already wasted 2 minutes of your life. Okay, so gastroesophageal reflux disease. Brief overview. So under normal circumstances, any refluxed stomach contents are usually returned to the stomach by a secondary round of peristalsis in the esophagus. And then any swallowed saliva washes away that refluxed acid and neutralizes it. In gastroesophageal reflux, though, backwards flow of the contents into the esophagus can cause heartburn, which is medically known as pyrosis. When GER, gastroesophageal reflux, becomes frequent enough, that's when gastroesophageal reflux disease develops. And gastroesophageal reflux disease is just mucosal damage plus some of the other issues that we will address ahead. It occurs more than twice a week for at least a few weeks and can lead to eventual serious health problems. Okay, so GERD is a chronic condition characterized by the reflux of gastric contents, including acid and bile, into the esophagus, leading to troublesome symptoms and complications. It is typically associated with symptoms such as heartburn, regurgitation, and chest pain. The prevalence of GERD in the United States is around 20%. It is 0.1 to 5% in China and 10 to 15% in the UK. So the pathogenesis of GERD involves a multifactorial interplay of anatomical, physiological, and environmental factors. So the key elements of that are lower esophageal sphincter dysfunction, so LES dysfunction. The primary mechanism in GERD pathogenesis is malfunctioning of the LES. So the LES is a circular band of muscle at the gastroesophageal junction. The lower esophageal sphincter normally acts as a barrier, preventing reflux of gastric contents into the esophagus. But in GERD, the LES exhibits reduced resting pressure and impaired transient relaxation, allowing gastric acid and other contents to reflux up. This can happen with any motion or activity that requires abdominal straining, lifting, bending, or laying flat, or laying with your head lower than your abdomen. Another possible cause of gastric reflux would be a hiatal hernia, which is a condition where part of the stomach protrudes through the diaphragmatic hiatus and is associated with an increased risk of GERD. Hiatal hernias can disrupt the integrity of the lower esophageal sphincter, displacing it into the thorax and contributing to the reflux. Another possible cause would be impaired esophageal clearance. So that would be impaired esophageal peristalsis, which results in ineffective clearance of the refluxed material, which can contribute to GERD's pathogenesis. This impaired clearance allows prolonged exposure of the esophageal mucosa to gastric acid, which leads to inflammation and tissue damage. So following up on that exposure to acid, we have acid exposure and esophageal sensitivity. So chronic exposure of the esophageal mucosa to gastric acid causes mucosal injury and inflammation, which results in symptoms such as heartburn and regurgitation. Increased esophageal sensitivity to acid and other reflux contents contributes to the perception of symptoms. And then other contributing factors, which we will discuss much further, would be obesity, dietary factors, including high-fat diet, chocolate, caffeine, smoking, and then certain medications. But again, we'll get into that. So our etiology. The etiology of GERD involves a complex interplay of factors, including lower esophageal sphincter dysfunction, which we just mentioned. So dysfunction of this LES is the primary etiological factor in GERD. It can involve reduced resting pressure, transient LES relaxation, or just an impaired response to stimuli. These abnormalities allow the gastric acid, again, to reflux up into the esophagus. Then we have an impaired esophageal clearance. Weak esophageal peristalsis or decreased saliva production can disrupt the normal clearance of any of that refluxed material from the esophagus, thereby prolonging exposure to the gastric acid. And then delayed gastric emptying. Any sort of condition that causes delayed gastric emptying or gastroparesis can lead to gastroesophageal reflux disease by allowing gastric contents to accumulate and increase the likelihood of reflux. Conditions include diabetes and certain neurological disorders, which again, we will touch on. So our risk factors for developing GERD. Obesity is a significant risk factor for GERD as it increases intra-abdominal pressure and disrupts the normal functioning of that lower esophageal sphincter. Some studies have shown a very strong association between obesity and the development of GERD. A hiatal hernia can also be a risk factor. A hiatal hernia occurs when a portion of the stomach protrudes through the diaphragmatic opening or the hiatus into the chest cavity. This anatomical abnormality weakens the lower esophageal sphincter and impairs its ability to prevent reflux, which then increases the risk of GERD. It is present in about 25% of patients with non-erosive GERD. Smoking. So smoking, we know it's bad for us in many ways, but it has been consistently identified as a risk factor for GERD. It is believed that smoking affects the LES function and reduces salivary bicarbonate production, which the bicarbonate in your saliva is what is responsible for neutralizing any refluxed acid. So that would contribute to the development and severity of GERD symptoms. A number of dietary factors have been associated with an increased risk of GERD, which would include a high intake of fatty foods, spicy foods, chocolate, caffeinated beverages, decaffeinated coffee, so either way you're SOL, carbonated beverages, acidic fruits, like citrus and tomatoes. All of these can lower the lower esophageal sphincter pressure and directly irritate the esophageal mucosa, leading to reflux symptoms. There's also some medications that can lower the lower esophageal sphincter pressure, and those include anticholinergics, so like atropine, benztropine, scopolamine, diphenhydramine, your Benadryl, beta blockers, metoprolol, propranolol, calcium channel blockers, verapamil, amlodipine, nifedipine, cardizem, estrogen and progesterone, theophylline, all those can lower the LES pressure. And then delayed gastric emptying is also a risk factor for GERD. So therefore, anything that can slow gastric motility can increase your risk of developing GERD. So this includes alcohol, marijuana. Both of those can cause some gastroparesis. Opioids, we know when we have patients who are on opioids, our risk is them binding up and having slowed gastric motility. And something that you will probably see much more of, especially with its recent popularity in Hollywood and its FDA approval for weight loss, but you'll see it with your patients with type 2 diabetes as well as those who are using it for weight loss, GLP-1 agonists like Ozempic, Wegovy, Trulicity, and Mounjaro. If you have a patient that's presenting with a new onset of acid reflux and heartburn, it probably wouldn't hurt to double check their medication history and see if they are on a GLP-1 because it is a pretty prominent side effect. I personally take Ozempic. I'm a type 1 diabetic, so I'm technically not approved for it, but we are using it for weight loss and to get my insulin requirements down. And the first month was absolutely horrendous with gastric reflux style symptoms and nausea, vomiting, all of that. So yeah, if you have a patient that's presenting with these new symptoms, it's definitely something to consider. Make sure you're asking if it's not prescribed by you or another provider, if they're going to like a med spa or something like that. But that's a little tangent. Other factors that can increase your risk of developing GERD would be consumption of large meals, laying down too soon after eating, snacking late at night. All of those increase your risk, and risk is also increased in patients that have any conditions that increase the risk of gastroparesis. Again, so not just meds that can do that, but conditions like diabetes can cause gastroparesis, hypothyroidism, scleroderma, Parkinson's, multiple sclerosis. There's a number of different like neuro disorders that can cause gastroparesis. So our subjective data or symptoms that the patient might complain about. So heartburn is going to be the hallmark symptom of GERD. It's described as a burning sensation or discomfort that typically occurs behind the breastbone sternum area and radiates upwards toward the neck. It's often worsened by laying down or by bending over. Regurgitation, so that'll refer to the backflow of any stomach contents, including acid and food, into the mouth or the throat. It is usually experienced as a sour or bitter taste and is often accompanied by a sensation of liquid coming up into the throat, maybe a little burning. Some chest pain. Chest pain related to gastroesophageal reflux disease can mimic symptoms of cardiac origin, which could lead to some diagnostic challenges. The pain may be burning, squeezing, or pressure-like in nature, and can sometimes radiate to the neck and arms or back. So it is typically exacerbated by meals or lying down and relieved by antacids. So if you have a patient complaining of some new chest pain, those would be questions to ask to help guide your diagnosis. Another symptom they might complain of is dysphagia or difficulty swallowing. That can occur with GERD just due to the esophageal inflammation or the presence of strictures. Patients may experience a sensation of food sticking in the chest or the throat and may need to swallow multiple times to clear the obstruction. Burping as well as water brash are also possible symptoms. Water brash is just like reflex salivation. Odonophagia. Odonophagia refers to the pain or discomfort experienced during swallowing. So maybe they don't necessarily have a hard time swallowing, but they just have pain when they do. And GERD, that may be associated with esophageal inflammation or the presence of strictures. And so you want to be careful with your questioning and observation during the exam to help identify these symptoms. A chronic cough. So that is a common esophageal manifestation of gastric reflux. It is often described as a dry, non-productive cough that is worse at night or upon wakening. It is thought to be triggered by the reflux of acid into the larynx and the airways, and that can eventually lead to laryngitis or hoarseness. So reflux-induced laryngitis can present as hoarseness, a raspy voice, or a sensation of a lump in the throat, like a globus sensation, and it is due to irritation and inflammation of the laryngeal tissue caused by gastric acid reflux. Your patient may complain of having sleep disturbances. Because GERD symptoms get worse when lying down, that would lead to sleep disturbances, and patients may experience frequent nighttime awakening due to heartburn, coughing, regurgitation, which would affect their overall sleep quality. It is important to note that individual experiences may vary. So your patient with GERD may not exhibit all of these symptoms. They may not exhibit any of them. So proper diagnosis and evaluation by a healthcare professional requires an accurate assessment. So be sure to note what makes the patient's symptoms worse, and just as important is what makes them better. So what physical exam findings might you see with GERD? They can be pretty nonspecific. So you might find some epigastric or retrosternal tenderness. So doing your physical exam, you could elicit some tenderness with palpation of the epigastric region or retrosternal area. The tenderness can be indicative of esophageal inflammation or irritation caused by GERD. With that said, this seems to vary depending on the source you check, because our Dunphy text says that the epigastric and retrosternal pain is more common with peptic ulcer disease than it would be with GERD. So that might be a very non-specific finding, but something you may see. You might have some extra esophageal findings. So GERD can manifest with symptoms such as the chronic cough mentioned before, hoarseness, and throat irritation. So during your examination, the presence of these symptoms could be noted and further evaluated to determine their association with GERD. There might be signs of weight loss or malnutrition. In severe cases of GERD, chronic reflux and associated symptoms can lead to weight loss or malnutrition. So during the physical exam, looking for signs such as reduced body mass index compared to previous measurements, muscle wasting, or nutritional deficiencies. Oral findings you might see: chronic acid reflux can definitely impact your oral health. So dental erosions, especially on the posterior teeth, your molars, may be observed during the examination. Additionally, there could be some inflamed or reddened oral mucosa. In some individuals, GERD-related symptoms can cause respiratory distress. So looking for signs such as wheezing, shortness of breath, increased respiratory effort. Looking for signs of a hiatal hernia, which is again a common contributing factor to GERD. So during your examination, palpating the stomach and looking for a palpable mass or abnormal contour in the upper abdomen that would be suggestive of a hiatal hernia. And for this last one, I don't know how often we would be doing this necessarily in an office visit, but you may have a positive fecal occult on a rectal exam, which could indicate irritation of the esophageal endothelium. It is important to note that the physical examination findings associated with GERD may be pretty nonspecific and can overlap with other gastrointestinal disorders, other respiratory conditions. So therefore, the clinical history, patient presentation, and further diagnostic tests will play a crucial role in confirming your diagnosis. So what differential diagnoses are we looking at with GERD? Peptic ulcer disease, which is characterized by mucosal erosion or ulceration in the gastrointestinal tract, commonly in the stomach or the duodenum. Symptoms for PUD include epigastric pain, burning sensation, and acid reflux, which overlap with the symptoms of GERD. So diagnostic tests like endoscopy and H. pylori testing can help differentiate between the two conditions. Okay, so eosinophilic esophagitis, or EOE. EOE is a chronic immune-mediated disorder characterized by eosinophilic inflammation in the esophagus. It can present with symptoms similar to GERD, so heartburn, dysphagia, regurgitation. The presence of esophageal strictures and lack of response to acid suppressive therapy and eosinophilic infiltration on esophageal biopsy can aid in distinguishing EOE from GERD. Okay, so one of our other differential diagnoses could be functional dyspepsia, which refers to a group of symptoms such as epigastric pain and the feeling of being full much sooner than you normally would, without evidence of structural abnormalities. It can overlap with GERD symptoms, making it a potential differential diagnosis. The clinical features, response to acid suppressive therapy, and exclusion of other causes help differentiate functional dyspepsia from GERD. You could also consider biliary disorders such as gallstone disease or biliary colic, which can cause symptoms similar to GERD, including epigastric pain and regurgitation. Evaluation for these conditions with imaging studies, liver function tests, and ultrasonography can help identify biliary disorders as an alternative diagnosis. Cardiac conditions, particularly angina and myocardial infarction, can present with symptoms that mimic GERD, such as that retrosternal pain and chest discomfort. So differentiating cardiac conditions from GERD requires a comprehensive evaluation, including an EKG, cardiac enzymes, and stress testing. Functional heartburn refers to symptoms similar to GERD in the absence of objective evidence of acid reflux. It's diagnosed after excluding GERD and other causes through comprehensive evaluation, including ambulatory pH monitoring and impedance testing. It is important to consider these differential diagnoses in patients presenting with symptoms suggestive of GERD and a detailed clinical evaluation, including a thorough history, physical examination, and appropriate diagnostic tests is essential for accurate diagnosis and effective management. Okay, so what are some of those labs and diagnostics we would consider? There is no single gold standard test for the diagnosis of GERD, and diagnosis is usually based on a combination of clinical symptoms, response to treatment, and any additional tests to rule out other potential causes. So that said, if a patient is unresponsive to therapeutic intervention after 4 to 8 weeks or diagnosis of GERD is unclear, we as providers can definitely order an esophagogastroduodenoscopy or an EGD. That upper endoscopy allows for direct visualization of the esophagus, the stomach, and the duodenum, and it can help identify esophageal inflammation, erosions, strictures, and other structural abnormalities associated with GERD. Biopsy samples can be obtained to rule out other conditions and evaluate for complications like Barrett's esophagus, which we'll discuss later. Ambulatory esophageal pH monitoring measures the frequency and duration of acid exposure in the esophagus over a 24 to 48 hour period. pH monitoring can help differentiate pathological acid reflux from physiological acid exposure, aiding in the diagnosis of GERD. Esophageal impedance pH monitoring. That measures the retrograde movement of both acid and non-acid substances in the esophagus, and it can detect both acid and non-acid reflux events and help identify weakly acidic or weakly alkaline reflux, aiding in the diagnosis of GERD and distinguishing it from other conditions. We could also do esophageal manometry, which measures esophageal motility and assesses the function of the lower esophageal sphincter. It helps to identify any abnormal esophageal peristalsis or any lower esophageal sphincter dysfunction. Manometry is particularly useful in evaluating patients considering anti-reflux surgery. We could do barium swallow radiography, which involves fluoroscopic imaging of the esophagus after ingestion of barium contrast material. It can detect structural abnormalities such as hiatal hernias, strictures, or esophageal motility disorders that may contribute to GERD symptoms. It is not as sensitive as endoscopy, but it can be performed in cases where endoscopy is contraindicated or unavailable. For instance, if you have patients that would not be able to tolerate endoscopy for respiratory issues. We can do esophageal biopsy, which is done during the endoscopy and can help rule out other conditions that mimic GERD, such as eosinophilic esophagitis. Biopsy samples can be examined for eosinophilic infiltration, cellular changes, which would be evidence for Barrett's esophagus. And lastly, while there is no specific blood tests to diagnose GERD, there may be some that are useful in ruling out other potential causes of symptoms, such as anemia, thyroid dysfunction, cardiac origin, anything like that. The main goals of our plan of care are to eliminate or reduce symptoms as fast as possible. We want to prevent or reduce post-meal symptoms and exercise-induced symptoms, prevent or reduce complications such as esophageal stricture, esophageal ulcer, Barrett's esophagus, pulmonary aspiration of gastric contents, and esophageal hemorrhage. So Barrett's esophagus is a condition characterized by the replacement of the normal lining of the lower esophagus with a type of tissue that is similar to that of the intestines or the stomach. It is considered a complication of long-standing gastroesophageal reflux disease and is associated with an increased risk of developing the cancer esophageal adenocarcinoma. The normal lining of the esophagus is composed of squamous epithelial cells, but in individuals with GERD, chronic exposure to stomach acid and other irritants can cause the normal squamous cells to be replaced by columnar epithelial cells, a process known as intestinal metaplasia. This transformation occurs as a protective response to chronic injury. So one of the biggest portions of our plan of care is going to be pushing for lifestyle modifications. We're going to want to encourage weight loss in overweight and obese individuals, as excess weight can contribute to the GERD symptoms. We're going to push for dietary modifications. So advising patients to avoid trigger foods and beverages, such as fatty foods, spicy foods, chocolate, caffeine, alcohol, and acidic foods. You want to encourage smaller, more frequent meals. So instead of 3 large meals a day, maybe 5 to 6 smaller meals, and to avoid lying down immediately after eating. We are going to encourage smoking cessation, as smoking can exacerbate GERD symptoms and impair esophageal healing. And we might as well add in cessation of alcohol and marijuana here as well. The next step of the plan of care is patient education. We are going to discuss, again, these different GERD triggers, so lifestyle modifications and the importance of adherence to a medication regimen. For mild GERD, lifestyle modifications may be enough to provide relief, but for those with anything more than mild symptoms, pharmacologic interventions are needed. So we need to educate the patient on the possible side effects of proton pump inhibitors, so PPI-associated pneumonia, C. diff infection, osteoporosis, and vitamin B12 deficiency are things to note. We want to encourage patients to elevate the head of their bed and avoid lying down for at least 2 to 3 hours after eating. We'll educate patients on the potential complications of untreated GERD, such as Barrett's esophagus and esophageal adenocarcinoma, as well as the importance of regular follow-up and surveillance. Okay, so the next step in our plan of care would be medication management. Proton pump inhibitors are usually initiated as the first-line treatment to reduce gastric acid secretion and promote esophageal healing. We'll start with a dose once daily prior to the first meal of the day for a course of 8 weeks, which we will then follow up with the patient and assess the patient's response to that therapy and adjust the dosage and duration of PPI therapy based on their symptom severity and response to the treatment. For severe symptoms or documented Barrett's esophagus, twice daily dosing and chronic maintenance therapy might be indicated. We could consider histamine 2 receptor antagonists, H2RAs, as an alternative or an adjunct to PPIs in patients with milder symptoms or as maintenance therapy. We could also use prokinetic agents in select cases where there may be impaired esophageal motility. We could use prokinetic agents such as metoclopramide or Reglan to improve esophageal motility and reduce reflux. Next up in our plan of care is possible referrals we might need to make. So we would consider referring the patient to a gastroenterologist for further eval and management if the diagnosis of GERD is uncertain or maybe the patient has atypical symptoms. We would also consider if initial treatment with lifestyle modifications and over-the-counter medications was ineffective. Maybe the patient requires endoscopic evaluation, specialized testing, or consideration for surgical intervention. You would want to make that GI consult. And then other consults you would make would be be dependent on specific needs of the patient. So maybe they need to see an otolaryngologist for evaluation of ear, nose, and throat symptoms associated with GERD. They might need to see a pulmonologist if they are having some of those respiratory symptoms like the persistent cough or suspected aspiration. You might want to refer them to a sleep specialist for assessment of any sleep-related symptoms such as nocturnal reflux or obstructive sleep apnea. And then our follow-up process. The initial follow-up visit should be 4 to 8 weeks after initiating treatment, just to assess the symptom control, the patient's response to medication, and patient adherence to the lifestyle modification. At that point, we would review the patient's response to the treatment and adjust the treatment plan as necessary. We would provide the patient education regarding chronic nature of GERD and the importance of long-term management as well as lifestyle modifications. For ongoing follow-up, we would schedule regular follow-up visits based on the patient's response to treatment and their symptom severity. So we would assess the need for ongoing medication therapy, adjust doses as required, and address any medication-related concerns for the patient. We would evaluate their adherence to lifestyle modifications and provide support and guidance as needed. We could consider periodic endoscopic surveillance for patients with Barrett's esophagus or other risk factors for esophageal adenocarcinoma. And lastly, the referral and follow-up process should be tailored to the individual patient's needs, their symptom severity, and their response to treatment. Collaboration between primary care providers and specialists is essential for comprehensive and effective management of GERD and prevention of those long-term complications. So I thank you for listening to my down and dirty on gastroesophageal reflux disease. Here is a bunch of references for all of the information and some of the images I've used. Any image without a citation in the slide was created either by me or by an AI image generator with prompts that I gave it based on GERD, which is kind of fun. So hope you all enjoyed it. Have a great day, and I look forward to seeing your presentations. Thanks.